And good evening to everybody that is online. So we'll start this series of asthma and COPD with COPD because I remember that our first Zoom session was about a patient that was asthmatic. That's why I changed. So just to remind one another, most of the things that we'll be discussing will be taken from the gold, but also we will be mentioning what the government, because we work for the Department of Health, what are the standards based on EML and the standard treatment guideline. I also included some of the data or recommendation from up to date. So this will be our smoke and fire for this evening, will be to dive into the basics of COPD. And why did I choose COPD instead of starting with asthma is because we need to be mindful of the fact that COPD is currently among the top 3 causes of death worldwide. So it is worth for all of us to know how to manage COPD. And 90% of these deaths occur in countries like the one that we live in and we practice. So that is another reason for us to really do our best, because we contribute to 9 out of 10 deaths that are related to COPD in the world. So, and first, we need to remember what is the definition of COPD, and one of the key words there is treatable, because the tendency is always been to be defeated after we've diagnosed our patient with COPD, and we tend to think that we don't have anything to offer to them that could make a difference. So not only it is common, not only it is preventable, it is a treatable disease. It is characterized by persistent respiratory symptoms that result from airflow limitation, and that was caused by significant exposure to noxious particles or gases, but they are also influenced by host factor. So we need to, as we deal with COPD, or as we deal with patients that we diagnose with COPD, we should not forget that not every single person with COPD was a smoker or is going through COPD because they chose to smoke. So those are factors that influence the disease development and progression. As you can see, there are genetic factors, there are age and sex that might impact on the incidence and even the progress of the disease. Individual that gets lung disease in their childhood might end up developing COPD as they grow, or when they get COPD, they will tend to progress quite rapidly. And the main factor, as we all know, is exposure to particles. But the poorer, again, you are, or our patient will be, the higher the risk for COPD, being it incidence or progression. And again, it's not only about asthma and COPD overlap, but patients with asthma that are not controlled will end up one day developing COPD. So the main factor is smoking. Again, when you check the standard treatment guideline, there is a table there when they try to differentiate asthma and COPD. And among the criteria that I use in history to try to differentiate asthma from COPD, it is mainly it's a history of heavy smoking, and in bracket, they talk about more or more than equal or more than 15 pack years. But it's not all about smoking tobacco, but also smoking cannabis, especially for us practicing in Eastern Cape, where there is quite a large chunk of the population that enjoy or at the time indulged in cannabis use. So, but as we were saying again, 20% of patients with COPD, if we define COPD solely by lung function test, we will see that 20% of people that die from COPD never smoked. So, and whenever we take history, we should not only be focusing on asking patient about, did you smoke, are you smoking? But also be mindful of the fact that history of fume or dust exposure. So people might end up developing COPD because of the occupation or because of the domestic duties. And it is not uncommon that we get to attend to ladies or older ladies that have COPD that will tell us that they never smoke, and the explanation might just be that they've been exposed to fumes, biomass or cooking fumes most of the time. And there are papers out there that talk about the role of TB and the COPD association, although the latest guideline or papers from Gold try to dismiss the link or the causality between that arise from TB. So it is worth to know because you might get colleagues that will quote these papers, and it is not only papers from South Africa. There are many papers out there. As you can see, there is a paper from Philippines, a lot of paper from Asia, as you can also see there, that have linked TB or previous TB to the risk of developing COPD later in life. So now, how does COPD present? We need to know that our patient with COPD will present either as chronic stable patient, but we need also to remember that from time to time, they might get exacerbation, especially if they are not treated properly or they continue to get exposure to those noxious particles and fumes. So what are the cardinal signs and symptoms of COPD that we need to be mindful of? It is dyspnea, it is cough, and it is sputum production. We need to remember this because later on, when we talk about exacerbation, for example, one of the grading is based on how many of these cardinal symptoms are present during the exacerbation for you to grade your patient exacerbation severity. And we need also now to get used not only to inquire about the history of smoking or exposure, being it domestic or occupational, and be mindful of the fact that TB might also be in the background, the history of TB, as we deal with patients that we suspected that they might have COPD or that we diagnose with COPD. We need not only to get the symptoms, but to get used to assessing these symptoms using tools that are available there. And the symptoms and signs are assessed by using the modified MRC for the dyspnea. But if you want to be more comprehensive, for example, you can use the COPD assessment tool. I've restricted myself to these two tools. There are more than these, but these are the one that we will see later on when we want to classify our patients. So we know that they will come with dyspnea, cough, and sputum production. We need to be able to assess and grade these symptom and sign using these tools. So it's not only about diagnosing COPD, thinking of COPD, diagnosing COPD, recognize COPD, but also assessing the severity of COPD signs and symptoms using modified MRC and COPD assessment tool. And this is just an idea for us to know what the modified MRC entails. So basically your patient will be between, usually if you dismiss the one that is not short of breath or only short of breath with strenuous exercise, the patient will be scoring 1 to 4, 4 being the maximum, when the patient is so breathless that they are not able to leave the house, or they are short of breath just by trying to dress up. So as you can see, the Modified Medical Research Council, the MMRC, is basically only a dyspnea scale, while cardinal signs and symptoms of COPD are more than dyspnea alone. That's why the CAT is more comprehensive than the MMRC. But as you can see there, it will take us more time to score a patient using the CAT than using the MMRC. Maybe the trick will be while the patient is waiting outside, they can fill up, because they should be able to fill up the form, and as they get in, you score them, and as you can see, the total score will be 10. 10 is out of a maximum of 40 for the COPD assessment tool. And it takes care of cough, it takes care of sputum, the tightness of chest, how they function, activities, how the confidence to living home, how do they sleep, and how do they feel energy-wise. So those signs, as we say, or as we will come, our patient will come as chronic stable, but our patient can also come as exacerbation. Therefore, we need to know what is, or recognize what is exacerbation, because also exacerbation gives you an idea of the risk that your patient is at getting the disease worse, worsening, progressing, and even mortality increases with exacerbation. So recognize the characteristic of exacerbation are that those cardinal signs and symptoms will increase or worsen and beyond the normal day-to-day variation. And it is usually acute, but it can also be progressive. And when it does happen like that, if you only consider dyspnea, you might be in the dark, because you want to know if you are dealing with asthma or you are dealing with COPD. And when we talk about cough worsening, it will be about the frequency and the severity of cough that is increasing, that will determine that your patient is going through exacerbation. And when it comes to sputum production, it will be that the volume of sputum or the character, so the sputum that could have been clear, when it becomes purulent, it change color, your patient is going through exacerbation. You don't need to have all of them. If one of them has worsened, your patient is going through exacerbation. So, and not only these cardinal signs have worsened for us to decide that a patient is going to exacerbation, but the ultimate characteristic is it is worsening. That worsening should be sufficient enough to require change in the treatment. So the patient might need to increase the frequency of just the SABA that they were using, or the patient might need to come to the hospital, get extra treatment, being it antibiotic or steroid, or even get nebulization. So that will be a proof that the patient went through exacerbation. So now that we know who is at what is COPD, who is at risk of COPD, how does COPD present, and what is exacerbation, we need and how to assess for severity of cardinal sign in a stable patient. We need also to be able, whenever a patient comes to us, to grade the severity of an episode of exacerbation. So how do we grade the severity of exacerbation in COPD? Contrary to asthma, where we have a table that will tell us about the peak flow sometimes, or mainly how is the patient, what is the posture of your patient, how does your patient express themselves and so forth. In COPD, that table doesn't apply. In COPD, if you need, if you need to grade severity, you will not use that table, but you rather use which therapy was used to deal with the patient exacerbation for you to determine the grading of your patient exacerbation severity. So there is a way, one of the first way of grading severity will be after exacerbation was dealt with. So it will be based on which treatment was used. In that case, a patient with mild exacerbation will be the one that was only treated with short-acting bronchodilators. A patient with moderate exacerbation is the one that was treated by both SABA and antibiotic, or SABA and or oral steroid. And a patient that requires hospitalization, or a patient that went to emergency, in our case, it might be just to come to OPD, where they will be nebulized, or a patient with or without, on top of that, with or without acute respiratory failure, if they require hospitalization or they did visit the ER, those patients have went through a severe exacerbation. So this is the first way of grading exacerbation in COPD. The second way of grading exacerbation in COPD is based on symptom, as we said, how many of those cardinal symptoms the patient had. If they only had one of the three cardinal symptom, it means that the exacerbation was mild. If they have at least two of the three cardinal symptoms, that exacerbation was moderate. And if those symptoms were severe, enough to increase the respiratory rate significantly, to decrease saturation, to lead to confusion. And whenever they came and the response to the initial short-acting bronchodilator was not sufficient, and or they have all three cardinal symptoms, that patient or those patients experienced a severe exacerbation. It doesn't matter, because remember, the more severe the exacerbation, the more your patient is at risk of progression, the more your patient is will not be able to function, or the higher the risk for hospitalization. The cost is not only healthcare wise, but socioeconomic will be significant for your patient. So the last way of grading severity apply, but this one apply only to patients that were admitted, those one that were admitted. So there will be patients that will be graded as exacerbation with no respiratory failure. There will be patients that will be graded as going through exacerbation with respiratory failure, but that was not life-threatening. And there will also be the third category of patients that would be admitted because they went through acute exacerbation with acute life-threatening respiratory failure. The characteristics are there. So just to summarize, you get exacerbation. We know what does it entail. It means things worsen. Those cardinal symptoms worsen. How we treated the patient can assist us grading the severity. How much of these symptoms our patient had can help us grade severity of exacerbation for those patients that were not admitted. And for those that were admitted, on top of these two category ways of grading, we should also consider the possibility that they might have had acute respiratory failure or not. And when it was present, was it life-threatening or it was not life-threatening? So now that we know how to present, we need to know how to diagnose. So by the book, spirometry is required to diagnose COPD. Unfortunately, in our setting, currently in public sector, we cannot guarantee our patient to access spirometry. I just send a patient this week on Monday in private to go do a spirometry. People that are doing occupational health are offering the test, and it was under 300 rand. So for patients that can afford it, when you are not sure that you are dealing with COPD, because the treatment, let's agree that the management of asthma is different from the management of COPD. And if your patient can afford that 200 or 300 rand, you should consider picking up the phone, book your patient in private. They can go get the report, and that so that you know exactly what you are dealing with. So it is required. And what do we, it is required because, as you can see there, if you don't use spirometry, you might overdiagnose your patient for obstruction. And whenever you want to send your patient for spirometry, or you need to remember that if they were on a bronchodilator, it should be stopped. It should be stopped because We know that one of the criteria to diagnose COPD will be the absence of reversibility. And so if the patient is on a bronchodilator, the absence of reversibility might be due to the fact that they were under influence of the drugs. That's why we couldn't see the response, and we might misdiagnose our patient with COPD while they might be having asthma. So, and the holding time for treatment for bronchodilators will depend on which type of bronchodilator that the patient was on. Just to give you a difference between SABA and LABA, for example, if your patient was on SABA and they want to go for spirometry, you should advise them not to use it and for at least for up to 6 hours before undergoing that spirometry. And if they were on LABA, they should be off LABA for at least 24 hours. So what are we looking on to get on spirometry? We're looking to get an obstructive pattern, and we are looking to get irreversibility. It is a post-bronchodilator spirometry. If it gives us obstructive pattern and if it gives us irreversibility, it means we are dealing with COPD. What do we mean by obstructive pattern? There is obstructive pattern when your FEV1 over FVC ratio is less than 7, and irreversibility is determined post-bronchodilator, provided that the holding time was not ignored. First, you still have an obstructive picture, but on top of that, 10 to 15 minutes later, if the patient will be using, or if the operator will be using a SABA, they will reassess the patient 10 to 15 minutes after administering SABA. But if they are using SAMA, they will be reassessing the patient 30 to 45 minutes after administering SAMA. So, and this is the most common drug used. It is SABA, salbutamol. The dose to assess, it is 400 microgram. Ideally, they should be using a spacer, meaning we need to be mindful of how it will be done. It means 1 puff 4 breath. So basically, it will be only after 16 breaths that your patient will be reassessed for reversibility. And how do we decide that there is irreversibility? There should not be an increase of the FEV1 or FVC there should not be an increase by 12% or an increase by 200 ml. So if it is less than 12% or less than 200 increase after administration of the bronchodilator, it means there is irreversibility. And in the presence of an obstructive pattern, that patient can be diagnosed with COPD. But again, in our setting, for patients that will not have access to COPD, we can consider the risk because we know which patient is at risk. We might consider the presentation. We know how it does present, and therefore we can just have the part of irreversibility using a peak flow meter. We hold the bronchodilator if the patient happened to be on bronchodilator, as we spoke about it before, and we administer the same way that it is recommended. So it will be 400 micrograms. It's not that you give one puff or two puff, then you want to assess for reversibility. We know how long we should wait before we reassess our patient. And if they blow and there is a change that is less than 20% of the previous peak flow meter reading, we can infer that we can assess our patient as having irreversibility and infer, considering the history and the presentation, that our patient has COPD. So what we know why we test for irreversibility or reversibility, it is because obstructive pattern is found in both asthma and COPD, but what will differentiate asthma from COPD will be the reversibility in asthma, so a change of the peak flow reading by more than 20%, or if your patient had access to spirometry, it will be by more than 12%. So still, as we evaluate our patient, this is one of the things that we were not taught to do, and we never consider whenever we deal or after we've diagnosed our patient with COPD. These are bloods that need to be part of the evaluation, is that we need to determine our patient blood eosinophil count, because as you can see there, it is one of the valuable information that is needed whenever we consider to initiate ICS, corticosteroid, in our patient. And at the time also, whenever we deal with a patient that has a COPD that comes with dyspnea, we need to make sure that we've tested for the absence of anemia, because whenever there is anemia, we might consider that the patient is in exacerbation, while in fact that dyspnea was caused by anemia, or worsening of dyspnea was caused by anemia. So blood-wise, these are just the two main things that we can use. Eosinophil should be determined in every single patient, because one day we might consider, or we might choose, select which patient need or will benefit from ICS. And whenever our patient are dyspneic or the pattern of dyspnea change, we should not forget to assess for the presence or the absence of anemia, so that we can decide or attribute the dyspnea solely to either the disease that has progressed or the disease that did exacerbate. The other things that we need when we evaluate our patient will be pulse oximetry. As you can see, we don't always need ABG in our patient, unless really it should be unless the saturation is less than 88%. So that is the value of pulse oximetry in the COPD evaluation, is that it reduces the need for us pulling blood for blood gas. So you only select few patients, and one of the criteria easy to remember is that is only when we have a patient with saturation that is less than 88%, that if we have access to a blood gas, we should be pulling blood and for hypercapnia and pull blood for hypoxemia. What about X-ray? What is the role of chest X-ray in evaluating patients with COPD? We need to remember that chest X-ray is mainly ordered to exclude alternative diagnosis, not really to diagnose COPD. We exclude alternative diagnosis with chest X-ray. We evaluate for comorbidities. We look for complication like pneumonia or pneumothorax whenever, especially our patient symptoms have changed. And why don't we rely on chest X-ray to diagnose COPD? Because the sensitivity is very poor. In a population of moderate severity COPD, chest X-ray can only pick about half of the patient. We know which signs that we tend to look for whenever a patient with COPD have access a chest X-ray. It is mainly about flat diaphragm or the shape of the heart shadow that will be narrow and long on frontal X-ray. And again, on the lateral, we see there that flat diaphragmatic contour comes again, but there is a new element that we can look for. It will be an increase in the retrosternal airspace whenever we have access to a lateral radiograph. And maybe this is the time to remind one another when to order a lateral chest X-ray. And part of the complication, we can see bullae in patient with COPD. And later on, when the disease is advanced and we have access to a chest X-ray, looking back to prior X-ray, we might pick up the fact that after the patient have developed pulmonary hypertension and copulmonary, that the cardiothoracic ratio might have increased. So now, after evaluating our patient, we needed to treat a patient with COPD. Again, we insisted, and the talk today was to remind us that COPD is a treatable condition. And when we treat patient to reduce symptoms, but also to reduce the frequency and the severity of exacerbations, to improve tolerance to exercise, and to improve the patient health status. And for us to achieve these goals, we will need to box the patient so that we can choose the correct treatment for our patient. And how do we box the patient? As we can see, we should, going forward, never stop by assessing our patient as COPD only, but adding the A, B, C, or D to the COPD assessment. And these gradings are all based on how much symptom our patient has and what is the risk the patient is exposed to based on the history of exacerbation over the past 1 year prior the consultation. As we can see there, patients that are A or B would have had only one exacerbation in the past year, but one exacerbation that didn't lead to hospital admission, while patient C and D would have been patients that volunteer the information that they experience 2 or more exacerbation that didn't lead to admission, or they experience 1 or more exacerbation that led to hospital admission. Symptom-wise, patient A and C will be scored 1 or less on MMRC and less than 10 on CAT, while patient COPD B and D will be scored 2 or greater on MMRC and 10 or greater on CAT. Because ultimately, patient A are the one that will be offered in our setting SABA only, while patient in B will be offered on top of SABA, LABA, and C and D by standard treatment guideline will be offered ICS LABA combination. And which treatment are available in government? If you read the document from the government, you will see that the patient can be offered SABA, the patient can be offered LABA, or the patient can be offered the ICS and LABA. And there is also, although controversial, a role for theophylline. So these are the doses that we need to remember, all of us. It is written that the patient can be offered 100 to 200 microgram of that salbutamol sulfate is supposed to be 100 microgram per dose, not 10 microgram per dose. So it will be 1 to 2 puff, 8 hourly to 6 hourly, or as needed. As you can see there, regular and as needed SABA or SAMA improve symptoms. That's why they are prescribed to our patient. And if you have access to both, a combination of both SABA and SAMA perform better than each of these drugs individually. And when you compare SABA to SAMA, SABA perform better than SAMA. That is one of the reasons why currently you won't see the government buying ipratropium to be prescribed to patient, because if you give ipratropium, ideally your patient should also be on SABA, because they will tend not to respond as well as SABA patient if it is monotherapy. So it's just for us to understand all those standards and the prescription. We were used to prescribe ipratropium to our patient, but remember again, when you compare SABA and SAMA, for patients that need short-acting bronchodilator, SABA perform better than SAMA, but the combination of SABA and SABA is better than each of these drugs individually. So the LABAs that the government recommend will be formoterol fumarate at a dose of 12 microgram twice a day. Unfortunately, in Makiwane, for example, currently we don't have formoterol as a single drug. The formoterol that we have access to is formoterol that is already combined with ICS, and it is formulated at 4.5 and 9 microgram, not 12 microgram. And in that case, the dose will be 9 microgram 12 hourly, not 12 microgram. So, and as you can see, again, these are the benefit of putting your patient on LABA. So prescribing currently a patient SABA only, or prescribing SABA and ICS, because there are plenty patients still today on salbutamol alone and beclomethasone, we don't help those patients. If they qualify for LABA, they should be on LABA, because LABA or LAMA significantly improve the lung function, reduces dyspnea, increases health status, reduces exacerbation rate. And these are the goals for pharmacological therapy. So it is not a surprise that our patients keep on coming all the time with exacerbation, because they are only receiving SABA and ICS, which is suboptimal therapy, when they found themselves already at B, C, or D, because only patients that are A qualify for SABA. Any other patient should not be on SABA alone. They should be on SABA as a reliever with long-acting bronchodilator. So again, whenever people have access to both LABA and LAMA, they perform better than each of these drugs given individually. So there are even talks in private. You will hardly see nowadays patients that will be, whenever they are B, C, or D, you will hardly see as them on monotherapy. So, and if you see a patient on dual therapy, you just understand where the rationale comes from. And this is another drug that the government also consider for patient with COPD. It will be patients that are C and D in government. It is recommended that they should be on the combination of ICS LABA, not ICS SABA. It is ICS and LABA. So, and the one that the government that you can find in the standard treatment guideline is the combination of salmeterol and fluticasone. So all that we need to remember, it can come in various presentation, but all that we need to remember is that the maintenance dose of salmeterol is 50 microgram twice a day. So whatever device that you have, you just need to remember, if you have the 250/50, it will be one dose twice a day. If you have a 125/25, it will be 2 doses twice a day. If you have the this was supposed to be, if you have a 250/25, it will be 2 doses twice a day. So the dose, all that we need to remember, if it is formoterol in our setting, it will be 9 twice a day, 9 microgram twice a day. And if it is salmeterol that you choose for your patient, then it will be 50 microgram of salmeterol twice a day. The reason why the combination of ICS and LABA is recommended, it is because the combination is better than each of these drugs individually when it comes to improving the lung function, which is one of the goals, the health status, reducing exacerbation in patients with moderate to very severe COPD. That's why in the government setting, every single patient that is a C and a D must be, who is expected to be on ICS LABA. What is the role of oral glucocorticoid long-term of it? There is no evidence of benefit, and we still see a lot of patients. This is even by standard, by government standard. People must remember there is a patient with COPD should not be on long-term corticosteroid, oral corticosteroid. All that you are building up is Cushing syndrome. What about theophylline? Because we see patients that have been taking theophylline for 10 years now that are also symptomatic. So the recommendation is there, the dose is there, 200 milligram nocte. But as you can see, there is a moderate effect when compared to placebo, not compared to any of those first-line drugs that we've spoken about. And it doesn't have any effect on exacerbation. And remember that one of the goals of therapy is to reduce exacerbation. And we should be assessing our patient. If they are still symptomatic and they've been using theophylline for more than 12 months, it should be stopped. And I stop there. Thank you very much.
Thank you very much, Dr. Kabengele. I think I might have lost 3 minutes in the middle, not in the middle. I'll tell you, it not because of my Wi-Fi cut out, and I might at the end just record that with you. It's literally, I think, 2 slides that you did. So just to warn you, but we'll do that in a minute. I just want to open the chat. If anybody wants to raise any questions, you can either put up your hand or you're welcome to just unmute yourself and ask a question. So Doctor, there is a hand. Yes, Dr. Mbaye, but Dr. Bayer, just please unmute yourself.
Thank you, Doc. Thank you, Dr. Kabengele. I think it was really informative. I just have a few questions. I'm not sure. You were speaking about eosinophily with regard to the ICS treatment. I was wondering, what about the rapid testing of inflammatory markers when you're looking at the decision to give antibiotic? Is it of value? That's the first question. Can we do the inflammatory markers to inform the decision to bring in antibiotic on the acute exacerbation? The second question is, with regard to chest physio, what is your take home? What's your advice? And also the place of vitamin D and omega in terms of non-pharmacological therapy. What are you saying? Maybe the last question, sorry, because I have many. The last question will be, since the goal is to avoid exacerbation, what do you say about immunization, like pneumococcal infection vaccine, influenza vaccine, because these have been proven to play a role in exacerbation of COPD? I can stop there. Thank you.
Thank you. Okay, so I didn't cover the non-pharmacological. As you can see, there is not that they're not important. Yeah. So vaccine, every single patient with COPD should be receiving annual influenza vaccine. They should be vaccinated against COVID. They should be, depending on, all of them should be on offered pneumococcal vaccine. The type will depend on what is the patient age for the type of pneumococcal vaccination that will be offered. And even the vaccination for pertussis should be offered to those that were not vaccinated when they were young. So again, under non-pharmacological therapy, there are a lot of therapy out there, but there are also a list of therapy that don't have a proven benefit. So we will continue. This session was only the introduction. So we will list the therapies that are beneficial, and we'll list the therapies that are not beneficial. When it comes to inflammatory markers, they will talk about exacerbation. That is where really antibiotics play a role, and that is where, and at the time, the eligibility criteria for antibiotic is not solely based on on inflammatory markers in the blood, but the severity of the patient exacerbation. So we will talk about how to manage exacerbation the next time, and you will see that almost every single patient with moderate to severe exacerbation the bystander should be offered antibiotic. And if on top of that they have sputum that is purulent, or you have they are spiking temperature, or you pull blood and the CRP is elevated and the white cell count is high, you can prescribe antibiotic. But antibiotic can also be prescribed long before you get the blood result, but that apply to exacerbation. We will review those non-pharmacological modalities next time.
Okay, well, thank you, Doc.
Thank you very much, because that was a great teaser to say this is just part one. I assume we'll be continuing next week, Wednesday night, Dr. Kabengele, is that right?
Yes, with we will do non-pharmacological and deal with exacerbation.
Great. Yes, thank you. I just want to check if there's there's no hands up at the moment. Any other questions? And there's nothing in the chat.
There's something in the chat.
Is there something in the chat? Oh, let me just look. Oh, I can't. You know what? It might be because I got cut off. So can you just check in the chat if there's something I got cut off and yeah, I was one stage I wasn't actually on the call.
Is it still safe to use salmeterol regardless of the side effect on the Black population? So the side effect of salmeterol, it is the warning, it is in the asthma context, not in COPD context. So the use of LABA without ICS is only, it comes with a warning when you prescribe in an asthmatic patient, not in a COPD patient. And salmeterol here, even in a COPD here in our setting, is recommended as salmeterol with ICS, not salmeterol alone. And it was only formoterol that was recommended as formoterol alone. But when you read, salmeterol can be given in COPD, but never give LABA without ICS, being it black or white. When you prescribe it for an asthmatic patient, it would always be combined with ICS.
Thank you very much. You have some very good questions. Excellent. I think we're going to close down there. Dr. Kabengele, if you wouldn't mind staying on 2-3 minutes so we can just re-record those 3 slides and then I'll splice it all together.
No problem.
Thank you very much, everybody. I'll send around the link again early next week for next week, Wednesday evening, where we'll continue this great discussion. Thank you very much.